Okay, welcome everyone. Thank you for joining us for today's EACTA ICU webinar, Can We Avoid ECMO in the Management of Post Cardiotomy Shock? My name is Dr. Philippe Godard. I am the head of the Cardiothoracic ICU department at the Montpellier University Hospital in France. And I am also the chair of the ICU EACTA Subspecialty Committee. So I'm pleased to introduce the two moderators of that webinar. First is Dr. Peter Russell from Brussels, Belgium. He is an EACTA ICU committee member. He is also a cardiac anesthesiologist and intensivist at the Flemish University Hospital of Brussels, with a special assignment as the head of the transformation program of the cardiological care plane and clinical coordination of intensive care. He has a special interest in cardiac anesthesia, intensive care, patient blood management, TE, data registration and quality assessment and improvement, teamwork, anesthesia overseas, and so on. He is a past president of EACTA and served as a representative council member and board member for 16 years. He was an affiliated member at the ACA from 2014 to 2016. He is a member in the SCA and the ECMO, Dutch Association for Anesthesiology. He has more than 50 publications and book chapters. The second moderator is Dr. Daniela Passero, and she is from Turin, Italy, and she's working as a staff anesthesiologist of cardiac intensive care unit in the Department of Anesthesia and Intensive Care Medicine at the Città della Salute e della Scienza Hospital in Turin. Her main activities and responsibilities include organization of clinical activity of cardiac intensive care unit, infection monitoring role also. She has a clinical research activity on postoperative pulmonary complication and pulmonary hypertension in cardiac surgery, critically ill patients with sepsis and acute kidney injury, lab research on septic model and translational research in septic patients and cell culture, organ procurement activity and protective ventilation in lung donors. She is a member as the EACTA Representative Council and ICU and VAD and transplant committees. So now, please, Peter, come to introduce the webinar and the objectives. The microphone is yours, Peter.
Thank you very much, Philip, for this very nice introduction. I'm really excited for this webinar, which I hope you will be very happy with the end. And let me shortly introduce you to the objectives of this webinar. Actually, at the end of which you should understand the current evidence and the best practices, how to use mechanical circulatory support after post-cardiotomy cardiogenic shock, as well as to avoid it. You will get a better understanding of the indications and contraindications, as well as the different types of using ECMO and related devices in the treatment of post-cardiotomy cardiogenic shock. As well, you should understand how can we avoid and how we could use balloon pump, anatropes, and vasoporters in order to have the best treatment for these patients. We will address as well the use of additional forms of cardiac assist, temporary cardiac assist, like ventricular assist devices, and as well you will have a better understanding of how TE should be used in order to help the introduction as well as the proper functioning of this particular treatment. So I hope you were excited as I am about what's coming up. Just to make sure that you use this webinar appropriately, So we will address questions after each of the presentations. So please, if you have any questions, type them into your chat box, and we will bring them up during the presentation, and we will handle them and try to have some time for questions as well at the end.
So now our next speaker is Dr. Priya Menon. She is a senior consultant in the Department of Cardiac Anesthesia and Critical Care in Leipzig in Germany. Her center is EACTA Accredited Fellowship in Advanced Cardiac Anesthesia and Critical Care. She has a IAC diploma in transesophageal echocardiography. And finally, she is ISA President Award for Academic Excellence in 2017. Thank you again, Priya, for his talk entitled Routing Use of TE to Guide Mechanical Circulatory Support for Cardiogenic Shock. Thank you, Priya.
Hello everybody. I'm going to speak on routine use of transesophageal echocardiography to guide mechanical circulatory devices in cardiogenic shock. The objectives of my talk is to speak on the role of TE in intra-aortic balloon pump placement, left-sided Impella placement, and in veno-arterial ECMO placement. Intra-aortic balloon pump is one of the most common mechanical assist device for patients with low cardiac output syndrome after cardiac surgery, especially in developing countries. IABP is even placed before any high-risk surgical procedures in such countries. As you see in this figure, there is a balloon which is inflated. This balloon is typically inserted from a femoral artery into the descending thoracic aorta. And this balloon inflates when aortic valve begins to close. That means during diastole. When the balloon inflates, it displaces the blood into the ascending aorta and into the aortic arch. So there is an increase in the diastolic pressure in the ascending aorta, and there's an increase in the coronary perfusion pressure, and thus increase in the myocardial oxygen delivery. Immediately before the systole, that is just before the opening of the aortic valve, the balloon deflates. And as soon as the balloon deflates, it pulls the blood away from the heart. And so there is an left ventricle afterload decrease. Now the question arises, do you really need a TE for positioning an IABP? Because it's not discussed in guidelines. And most of the cardiologists, they use fluoroscopy in cath labs. In the ICU, the intensivist looks at the X-ray and says the balloon tip is just 2 centimeters above the carina. That means it's okay. The surgeon will look through the groin to manubrium distance and says, yeah, IABP position is okay. So why do I really need to have a TE for an IABP placement? That is pre-implantation. If a patient is having more than mild acute aortic regurgitation, if the patient is having a more than mild aortic regurgitation, the balloon, when it inflates during diastole, aortic regurgitation will increase. There will be increase in the LV dilatation, which is, of course, going to harm the already ailing heart by increasing the wall stress. So an absolute contraindication is a more than mild aortic regurgitation. There are some relative contraindications, which are pathologies of descending aorta and aortic arch. Aortic dissection is one of them. There are case reports where an intra-aortic balloon pump has been placed in patients who have aortic dissection, and the pump has been placed in the true lumen, and the patients have survived. Other than that, aortic aneurysm is a relative contraindication. Atherosclerosis, especially where plaques can be dislodged, is a relative contraindication. In patients who are in low cardiac output syndrome after a cardiac surgery, It's your own clinical judgment whether to use an IABP in this patient, and so think about the risk-benefit ratio before you insert in patients who have such relative contraindications. Now, the placement, as I said, can be through femoral artery, right subclavian artery, or through the ascending aorta. The balloon size depends upon the height of the patient, and there are 4 different sizes of balloon, which can start from 25 centimeters square to 50 centimeter. Irrespective of the size and the length of the balloon, important is that the tip of the balloon should lie 1 to 2 centimeters below the left subclavian artery, and the proximal part should not be sitting on the abdominal vessels. So the left subclavian artery and the abdominal vessels should not be occluded by the inflated balloon. So echo is important because it will tell us the correct position and the proper functioning of the IABP. The important 2 views in the descending aorta short axis view and descending aorta long axis view is important. Other than that, an aortic arch view, both short axis and long axis, is important. Now, once we have our guide wire placed through the descending thoracic aorta, we view both the descending aorta short axis and long axis view in the X-plane, and we see the tip of the guide wire. On this, you place the IABP. The IABP balloon, as I said, should be 1 to 2 centimeters below the origin of the left subclavian artery. Now, how do you know that it is below 1 to 2 centimeters below the origin of left subclavian artery? We see where we try to look at the descending thoracic aorta long axis view, and then we pull out the probe, the TEE probe, slowly until the view changes from the long axis descending thoracic aortic view to upper esophageal aortic arch short axis view. And then we see the left subclavian artery is coming out. It's taking off from there. When you see this view, you should not be seeing the IABP balloon. Now, we have pulled out the probe, right? So if supposing the probe was at 30 centimeters, and at 30 centimeters, you were seeing the descending aorta view, the descending thoracic aorta long axis view. And now you pulled out, say, around 3 centimeters, and at that you are seeing the subclavian artery. That means the balloon is 3 centimeters away from the left subclavian artery. Now, once the IABP balloon is placed, there are a lot of artifacts because of the large acoustic impedance mismatch between the blood and the gas-filled balloon, inflated balloon causing shadowing. So a direct imaging of device is impossible with the inflated balloon. But the catheter is visible only during systole when the balloon is deflated. But as rapid cycle of inflation and deflation, it creates a typical pattern, so we know IABP is functioning well. But what if we see large volume of bubbles in aorta? Then a balloon rupture should be suspected and the IABP should be immediately removed. To look at the correct functioning of IABP, we can measure the stroke volume, and by stroke volume, we can measure the cardiac output. So we know how to measure the stroke volume by taking the LVOT area and multiplying it by the velocity time integral of the LVOT. We get the stroke volume, and multiply the stroke volume with heart rate, and you get the cardiac output. So what I can say is you need a TE examination just before putting an IABP to see if there are any contraindications, during the placement to see if it is properly placed, and once it is placed, you should do a periodic assessment of the function. Next is Impella heart pump and how TE helps. Here I'm strictly going to speak on left-sided Impella pump, as you see here in this figure. This is one of a very commonly placed temporary mechanical circulatory devices these days, which is like a miniature ventricular assist device which contains this pump which is inserted across the aortic valve and provides continuous drainage of blood from the left ventricle and reinfuses it into the ascending aorta, regardless how the LV is contracting. There are several types of Impella devices starting from 2.5 NCP. 2.5 means it gives a 2.5 liter flow. CP gives a 3.3 liters flow, and as per FDA, they are allowed for 4 days. So it can be placed in a patient for 4 days. Then there is a Impella 5, which is put through cut down of an artery. Then there is LD, which is directly placed into the aorta. And there is RP, which is for the right ventricle failure. So despite differences in the insertion techniques and the maximum flow support of different Impella, the final placement is the same. The final placement means you have a pigtail here, you have an inlet area and an outlet area. The pigtail and the inlet area should stay in the LV, and the axial pump and the outlet area should stay outside the aortic valve in the ascending aorta. Now, do you really need a TEE for putting an Impella? A fluoroscopy can help. Of course, fluoroscopy helps in initial placement, but it can't detect the device position in relation to the subvalvular apparatus of mitral valve or the distance of the Impella inlet to the aortic valve. So you need a TEE. So initial placement under fluoroscopy and TE guidance, but later on to see if it is properly placed and for troubleshooting, you need a TE. Plus for contraindications. So before we place an Impella, we should know that the indication should be like a reversible myocardial ischemia or a cardiac intervention in severely diseased coronary artery patients. So you know that the patient will recover. So that's the indication. But there are contraindications. Contraindications like patients with cardiac tamponade, patients who have a severe aortic stenosis, patients who are with mechanical aortic valves, when there are mural thrombus in the left ventricle, a biventricular failure, when the right heart is also failing, it makes no sense putting only a left-sided Impella. Or large shunts in form of ASD and VSD, Impella should be avoided. Or at least you need to require more thought and more discussion before you insert a Impella. Severe aortic regurgitation, similarly as IABP, a severe aortic regurgitation is going to increase the LVEDP. So once you know that I need to insert an Impella and you know which type of Impella you need, a 2.5 or a CP, whatever the choice of the vessel, you insert the guide wire. So once you have a 2.5 or a CP, you are inserting it through the femoral artery. You confirm the position of the guide wire and you rule out dissection. Now the guide wire should cross the aortic valve and enter the left ventricle. And this you view through the mid-esophageal aortic valve long axis view. So wire is crossing the aortic valve and entering the LV cavity. It should not be too deep because it can cause arrhythmias. The guide wire should face the LV apex and not the mitral valve apparatus. If there is a new mitral insufficiency or you have tethered the mitral valve, it can also happen that once you cross the aortic valve, you can do the tethering of aortic leaflets. So there will be a new origin of aortic regurgitation. So here you have to rule out the tethering of aortic valve leaflets by using a biplane of the aortic valve. Immediately at this time, once the guide wire is in, Try to rule out the dissection, looking at the ascending aorta, the descending aorta, and the aortic arch views. Now you have confirmed the wire, which is in proper position. Now you'll place the Impella heart pump over this wire. Look at the mid-esophageal aortic valve long axis view. If there is any trouble advancing the device, look at the descending thoracic aorta and the aortic arch view and see if your wire is kinked. Now the device, your Impella pump, has crossed the aortic valve. You withdraw the wire and then finally check the position by transesophageal. As you see in this figure, the distance of the inlet pump from the aortic valve is 4.98 centimeters. That is too much. Inlet to the motor in mid-esophageal aortic valve long axis view, which looks like a teardrop here, should be only 3.5 centimeters. And it should be seen that this does not go and impede on the interventricular septum or into subvalvular apparatus. After this, we will put the color flow and try to see if there is any new aortic regurgitation and mitral regurgitation after the pump is inside. Transgastric mid-papillary view and transgastric left ventricle long axis view is very important because it shows you that the pump is not entangled into some subvalvular apparatus and it is facing the LV apex and not the mitral valve leaflets. Once we have looked at the inlet is properly confirmed, then we go and look at the outlet, Impella device outlet by mid-esophageal aortic valve long axis and short axis view. It's very difficult to see the aortic valve because of the artifacts, but if there is a regurgitation, it can be very easily placed by this. Now, when we talk about troubleshooting, we know that cardiogenic shock, it's a dynamic process. The patient will start improving, its heart may start improving. It can get better with the inotropes or it can still worsen. So interventricular septum position when the patient is on Impella is very important. In a properly functioning pump, the intraventricular septum is in the midline. But if the left ventricle starts worsening, the interventricular septum shifts towards the right. So here you may need to add more inotropes or you may need to increase the Impella pump speed. Now, if the interventricular septum is shifted towards the left, it means either the right ventricle is going bad or your pump speed is very high or the patient needs volume. In the ICU, with an Impella, a patient can have a new onset mitral regurgitation, which means there is a device migration. There can be ventricular arrhythmias, which also means that the migration of Impella onto the interventricular septum. T is also important when we want to wean the Impella. So here I would say that the take-home points for Impella is the correct position is when the inlet is 3.5 centimeters below the aortic valve, the device outlet is just above the aortic valve, and device is angled away from the mitral valve towards the left ventricular apex. An improperly placed Impella is either too far into the left ventricle, that's more than 3.5 centimeters. The outlet is too far into the ascending aorta, and the pigtail is in the subvalvular apparatus of the mitral valve or papillary muscle, and the device is angled away from the left ventricle. Now we come to the role of TE in ECMO. ECMO, as we know, is either I'm just going to talk on veno-arterial ECMO. So we have a peripheral or a central ECMO. Echocardiography trained physicians should be a part of a team which takes care of patients on ECMO. Now, when you have a patient in ECMO, TE helps in pre-implantation, during implantation, helps in troubleshooting, and during weaning. So pre-ECMO assessment, if a patient has an aortic valve insufficiency, there is an increase in the LV afterload when you place an ECMO in these patients. So when the afterload is increased because of initiation of a veno-arterial ECMO and an AR is there, it will increase further, and there's an LV dilatation, pulmonary edema, risk of subendocardial ischemia due to increase in wall stress and increase in oxygen demand. If a patient has got a PFO, and during weaning, if by any chance the right-sided pressures increase, there is a TR, then right to left shunt will occur and there will be hypoxia. You should try to see the aorta and see if there is any dissection. It's a relative contraindication. Embryonic structures like Cherry's network, they hinder the proper placement of cannulas and wires. Similarly, the pacemaker wires and defibrillator wires can also cause hindrance in placing these cannulas. A dilated coronary sinus may be present with a persistent left superior vena cava. And if you accidentally cannulate a coronary sinus with a persistent left SVC, there'll be low oxygenation with the oxygenated blood shunted towards the left arm instead of the right atrium. Now, when you need to cannulate, do you really need to have an echo, or fluoroscopy may help? There are no recommendations which is better. Each has its own advantage and disadvantage. Like echo, you have artifacts is a big issue, but cannulation complications like a pericardial effusion or a dissection can be readily seen if you have an echo. Now, role of TE during ECMO cannulation, you need to know certain views which are important. The most important view is a bicaval view and an inferior vena cava view. Venous cannulas can be in the right atrium, in the superior vena cava, or in the inferior vena cava. Guide wire should be visualized in the mid-esophageal bicaval view, and you should also see a modified bicaval view. Modified bicaval view, you see the tricuspid valve. So you see that the guide wire is seen in both vena cavas and doesn't go into tricuspid valve or into the right atrium or into the PFO. So keep visualizing the guide wire when you thread the cannula over the guide wire. In peripheral veno-arterial ECMO, the drainage cannula should be at the level of inferior vena cava and RA junction. When you talk about arterial cannulation for ECMO, the arterial cannula can be in the femoral artery, into the axillary artery, or into the ascending aorta. Other than that, the important views are a 4-chamber view and an RV inflow-outflow view. An RV inflow-outflow view is important because it helps you to rule out any new pericardial effusion. And a 4-chamber view helps you to monitor the chamber size, the atria, the ventricle. When the ECMO is functioning and the LV becomes worse, there is LV distension. There is a new onset mitral valve regurgitation. The aortic wall doesn't open with each beat. There is no invasive blood pressure monitoring. You don't see any curve on the monitor. And then you see such a picture where there's a stagnation of blood in the ascending aorta, in the LV and the pulmonary veins. It means you need to vent this LV, either by putting an LV vent or doing a septotomy or adding an Impella along with the ECMO. When there is complications of ECMO, like a chamber is distending or chamber is compressed, or the ECMO flows are getting worsened, or the ventricular function is getting worsened, the main causes can be a tamponade, or a dislocation of the cannula, or the thrombosis of a cannula. these pictures are important. When you do an echo for ECMO, you need to know the bicaval view is the important view, mid-esophageal RV inflow-outflow view is important, an inferior vena cava view is important, and a four-chamber view is important. When you want to wean a patient from veno-arterial ECMO, we all know we start reducing the flow slowly, 0.05 to 1 liter every 4th hourly, and we look at the hemodynamic monitors. Along with that, when you want echocardiography monitors, you have to see that at a very low inotropic support, the patient has got an LV ejection fraction of more than 35%. His VTI of the LVOT, the velocity time integral, is more than 10 centimeters. Then you measure on the lateral annulus of mitral valve, how is the systolic wave? That's called as the SA. It should be more than 6 centimeters. And there should not be any LV dilatation or RV distension when you're weaning. I would like to invite you all for EACTA Echo course in June 2020, 27th to 30th June, to Hartzentrum Leipzig, Germany. I thank you all for your patient listening.
I hope that with this webinar, we've been able to provide you with a good overview how ECMO can be used and should be used, which are the caveats, and as well that ECMO should be seen within a whole arsenal of therapies. And I think that basically Dr. Antonio Rubino from Papworth, the UK, he explained very clearly the basics of ECMO treatment. He addressed as well the risks and the complications which are involved, which are really vast. And actually, he was mentioning, like other lectures, that the outcome after post-cardiogenic shock in patients who need ECMO is not very good. And in the best centers, it approaches somewhat about 1/3 of the patients who recover from ECMO. However, this is very dependent, as he mentioned, upon a very good selection. He insisted on the fact that such selection should be a multidisciplinary decision. And I think his final words was actually that every patient is different, ECMO is complex, and for every case we need a tailored approach in order to have the most benefit and avoid the side effects. Next was Dr. Isabelle Michaud from Brussels, Belgium, who gave us an overview of post cardiotomy cardiogenic shock. She mentioned the heterogenic literature, which is very difficult to interpret and to provide evidence what's the best treatment in this situation. She reviewed the use of balloon pump, which should not be dismissed lightly, and is probably very valuable, particularly in the preoperative setting in these high-risk patients, as well as in combination with ECMO in order to provide afterload reduction, which may be a major problem with ECMO. She reviewed as well some of the inotropics. She pointed out to the risk of very high doses of epinephrine. She mentioned let's say, somewhat care we should have with the use of milrinone. She reviewed as well levosimendan, which was very promising, but still waits to find its niche where it is most useful. Again, here, preoperative setting, it's probably the best way to use it. Next was Dr. Ouattara from Paris, who explained that next to ECMO, we may use other treatments, other assist treatments like ventricular assist device, be it left ventricle, right ventricle, or biventricle. And this should be seen more as, let's say, a second approach after the ECMO in order to bridge to something else, maybe an assist device for when you're likely in heart transplant. He reviewed as well the Impella device, which is very promising. Particularly, we know the high flow variants, as well the Impella which you can insert surgically. from within the apex or to sternotomy, as well as the new upcoming Impella for right ventricular assist. All very promising, but still very early phase studies. Dr. Priya Menon from Leipzig gave us a good review how TE guidance should be used in the insertion of ECMO cannulae, balloon pump, as well as Impella. Not only insertion, but as well in the daily follow-up of this patient, TE guidance is of paramount importance. Finally, Dr. Philippe Godard, he gave us the viewpoint from the intensive care to these patients. And with that, I think, I hope we have given you a good overview, which will allow you to make better use of ECMO in your patients. I really hope that you enjoyed this webinar. I wish you a very good evening. Thank you for your participation from wherever you are listening or looking. And now I'm giving the final words from this webinar to Dr. Godard. Dr. Godard, the webinar is yours.
Thank you, Peter, for this point-by-point wrapping up. Now, I think we are good for now. Thank you, everyone. It was a pleasure being with you today. As a take-home message, I would like to say that VA ECMO for refractory post-cardiotomy cardiogenic shock needs to be started early when inotropes don't work and needs to be customized to patient and surgical situation, including a combination with intra-aortic balloon pump. Left ventricular unloading is mandatory and minimal pulmonary flow needs to be preserved as much as possible. Anticipation or prevention is a key point for the use of balloon pump and probably levosimendan in selected cases. Selective left ventricular support or combined ventricular assist devices are promising options. TE is absolutely essential for the indication, the setting up, the follow-up, and the winning of mechanical circulatory support. It's time now to close the session. On behalf of all speakers and moderators, I would like to highlight and emphasize the value of Professor Mohamed El Tahan as EduCom Chair, being instrumental in organizing this EACTA webinar. This is my pleasure to introduce Professor Fabio Garacino, the President of EACTA, to conclude and close the webinar. Please, Fabio.
Good evening, everybody. Dear colleagues, due to unpredictable technical problems, I'm not able to lively connect with you at the end of this webinar, but I really wanted to thank all the people who made this webinar happen. So it is a pleasure for me, on behalf of the EACTA Board of Directors, to thank the speakers who did an excellent job, and we are very grateful to them for their commitment to EACTA. We know how hard it was to prepare the lectures, to go through the rehearsals with Professor El Tahan in order to make everything work fine tonight. So many thanks to all the excellent speakers. A special thank to the ICU subcommittee. All these educational activities are prompted by our subcommittees, are supported by the subcommittees, and we are very, very grateful to our colleagues and friends in the subcommittees for supporting these educational activities. I really wish to thank a lot the sponsors who supported us and allowed us to make this webinar possible. So I really thank Abiomed and Orion Pharma for their support. We are really grateful. They are supporting not only this webinar, but in general, our educational activities and scientific activities. And so we consider them really part of this team producing education and scientific activities for our community. Let me thank the team from Rome, the team from AIM, our association management team. They did an excellent job in supporting and backing all this activity. And last but not least, as we used to say, a great thank to the educational committee of EACTA and to its chair, Professor Mohamed El Taan, who is so active and is supporting, promoting, and managing all these interesting educational activity. Many thanks. Well, we apologize for not addressing all the answers. This is due to the limit of time, but EACTA will publish all the answers by speakers on the website. So before saying goodbye, I really wish to remind all of you that the next EACTA webinar will be in March 2020. So keep on following us. Thank you so much for attending and joining. Bye-bye.